Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Today's topic is overcoming value-based care adoption. My co-host and moderator of the chat, Dr. Dan McCarter. Dr. Dan,
Hey, Faisal. It's great to be with you this evening.
gosh, Dr. Dan, today I know it's a Tuesday, but my goodness, it feels like it's already like Thursday or Friday.
Absolutely. Absolutely. And this is a great topic this evening. I know lots of doctors are working on adopting value-based care, and it's top of mind how to do everything and keep all the plates spinning. So looking forward to this discussion.
Yeah, practices are transitioning to value, and most of them are finding themselves in these hybrid situations, where they're essentially still these situations that are still based in fee for service, but now they also got to do some of the value work, and they got to do all this documentation on top of taking on risk as well. The doctors are already so busy. But here today to talk about how to overcome value based care adoption is Dr. Matt Lambert. Dr. Lambert, welcome.
Hello. Thank you so much, Faisel, Dan. Happy to be here.
I really appreciate you taking time from your time away from the world to join us tonight to talk about this topic.
No, it's very important, and it's a nice break from a working vacation, I guess we'll call it. But nowhere else I'd rather be except maybe on the trout stream after we're finished here.
Well, Dr. Lambert, you've done so many EHR implementations over the last 20 plus years. I mean, how'd you get into that?
Yeah, I guess I'll start with like any reasonable story. I'll blame an old friend, right? My medical school roommate, Dr. Trenner Williams, was a family medicine physician trained in Kaiser in Southern California, and we were actually, and he saw this coming around 20 years ago, and decided that if we were going to make this change, that we needed to have physicians lead it and embrace it, right? So he got involved in the technology space, and then right around the time when the Meaningful Use Bill and the ACA came together, that created a lot of synergy between these two plans. We started a firm in DC, which is my home, called Clinivations. And again, that was a physician-led consulting service around all things technology. And that eventually became part of the advisory board. And of course, now the advisory board is a part of Optum. But along the way, we helped health systems all around the country select, implement, and get value out of their electronic health records. So I had the honor to lead initiatives all over the country, mostly Athena, Cerner, and Epic. Did a lot of work with Broward and their Cerner implementation down in Southern Florida. And also was the Chief Medical Information Officer for New York City Health and Hospitals, which is our nation's largest public health system. And boy, I thought I learned a lot about how everything comes together in DC, but I also got a master class of that in New York City. So it's been a remarkable journey, and one that led directly into Curation Health, because one of the things that we through embracing technology, one of the things that we came across very early on was an early HCC calculator, something that we would build into Epic or build into Cerner, and that would present the provider there at the point of care to say, this is a chronic condition for this patient in a value-based care program, and we need to make sure that it's captured this year. And so that adoption of the technology led directly into HCC and RAF and quality capture. And then at Curation Health, where I am the Chief Medical Officer now, we've built off of all of those lessons and have technology and services that help practices who want to make the transition to value-based care. We help them modify their technology and modify their delivery to help them get there. And it's interesting, more often than not, we say a health system or a large group will say we want to go to value-based care, and the payers will drive them there, but they really don't have a full understanding of what that's going to take, of how big of an operational shift it is. I know both of you know that very well, but it's not a subtle shift to move fully to value-based care. So yeah, it's just a fascinating time of care delivery, of of adopting technology, of policy, of new initiatives, and really just trying to embrace all that to move things forward into something that's more sustainable. Because I think, there are a lot of things that we can debate around fee for service and around the current state, but I don't think anyone would debate that it's not sustainable and we need to do it better.
With when you're dealing with some of the smaller practices, in particular, these smaller traditional practices, what are some of the simple things that you've been able to do to help doctors like adopt value-based care? You got these traditional small practices, and now they're ready to make the move. Like, what are some of the things that you've been able to do with Curation Health to help them actually make that happen?
Yeah, no, that's a great question. We are able to provide some scale that a small practice can't. All right, so we have a lot of alumni from the advisory board and from Clinnovations and Optum and even Evolent who know this space pretty well, and we're able to provide some expertise and services, and now virtually to multiple small practices around the country that they wouldn't necessarily have that. And that's not all that different than maybe some of the things that Caravan Health is doing in the ACO space. We're helping these small practices create scale. So we're able to provide some services there. We're able to make it easy with the technology. So one of the things historically we've dealt with a lot of again, a lot of the really large electronic health records, Cerner, Epic, Athena, but a lot of these small practices don't have the margin to afford them. So our technical team, bless their hearts, I don't know how they did it, but they found a way where we're able to get insights through the browser. So if the API, maybe the electronic health record doesn't have really robust APIs, our team has figured out a way to get information directly into the browser, into the Google or to the Microsoft Edge browser that reminds the provider that they would need to capture this particular complexity or close this particular care gap. So we've been able to really use some good technology, even or some places that can't really support a big tech team. So I think those are probably the two, the people in technology that help do that. And then just bringing lessons learned. There's so many smaller practices moving together in this space and just building on things real time that we're learning that we've seen in one place that maybe worked, or might work here, or might work there. And just building off of that learning is really been a help to the small practices doing it. It is, it's remarkable. I love the concept of I think we all grew up with a small community practice, small practice supporting us, and those relationships are so important, and especially in the value-based care world. But it's tough, man. Running a small practice is a real challenge in 2021 for sure.
Most of us got into medicine to help patients. None of us got into medicine to do all the administrative tasks. I remember that was like probably one of the biggest shockers for me, was just the little bottom right hand corner, seeing all these non-clinical administrative tasks I had to do. How have you all been able to help improve that part of the work lives for clinicians?
Yeah. It's a good use of technology and of AI to do simple, repeatable tasks, right? We're not trying to replace clinical judgment. We're not trying to replace human interaction, but it's a good use of a piece of technology to keep up with the latest quality initiatives that are assigned to, let's just say, a United contract, or to keep up with the latest changes to volume 25 of the risk-based model when it comes out. To really just debride all of the stuff that doesn't help you directly with care or directly to capture the complexity of the care you're delivering, we just remove all of that. So that's a really good a way to use technology, and then let providers interact with patients and make clinical judgments and do a lot of other things like that. We also focus on the basics, especially when you're new to value-based care or new to adopting it. Focusing on the common conditions that drive a lot of cost and utilization, and making sure that you're maximizing the care of those and the documentation associated with that. Because CMS, it's not how sick your patients are; it's how sick you're communicating to CMS.
That's right.
Yeah. So
it's a medical complexity of your documentation.
Yeah. But and I look forward to a time when I think we'll work through that. Right. Usually we think of prospectively. We think we'll capture these. They'll be submitted early once in the year. and we won't have any other, and it won't have to be maybe associated with an encounter. I think we'll eventually get there, almost a true prospective population-based payment, but we're not there yet. But yes, but focusing on the basics is always a really good way to start anything, right? And so making sure you're capturing all of those conditions, and then you can get more sophisticated over time. I think that's another way that we really are able to help drive the adoption of value-based care.